Ladies and gentlemen, thank you for joining the MPRO's Breast Cancer Screening, Risk and Preventative Measures. Your host for today is Julie Campbell. We'll begin.
Good afternoon and welcome to today's webinar presented by MPRO. This event is part of our Michigan Cancer Control Initiative, which aims to improve cancer screening rates throughout Michigan. If you would like to learn more, please visit cancercontrol.mpro.org. If you would like to download a copy of today's slides, we will place a link in the chat box where you can find them. Today's presenter is E.J. Siegl, Program Director and Nurse Consultant for the Breast and Cervical Cancer Navigation Program at the Michigan Department of Health and Human Services. At this time, I'd like to turn it over to E.J.
Thank you, and thank you for having me today. I need to apologize up front if my voice goes in and out. I think I'm battling a little bit of a summer cold here. So welcome, everyone. What I hope to do in the next 45 minutes or so, we'll have time for questions, is really three big things. I want to first talk about what are the differences among the national guidelines that are out there, specifically NCCN, ACS, and the U.S. Preventive Task Force. And these have to do with breast cancer screening for both average and high-risk women. I then am going to talk about some breast density and implications for mammography, because that's really become quite an issue during the last couple of years, and it's really been impacting not only the women who get mammograms, but also providers who give them the results. And then finally, I want to talk about the efficacy of different imaging modalities used for breast cancer screening, and I'm going to split it up regarding among average, intermediate, and high-risk women. So any talk that I do, I always like to do some statistics. Breast cancer is near and dear to my heart. My certification is in breast cancer, and I would love to eradicate the disease totally, but I don't see that happening anytime soon here. And as you can see from the statistics, every year in the U.S. alone, we diagnose over 240,000 women with breast cancer, and over 40,000 are expected to die. Here in Michigan, it's over 8,000 we diagnose, and over 1,400 are expected to die. And when we talk about breast cancer screening, really what we're looking at is we're aiming to reduce mortality and morbidity associated with advanced stages of the disease. And the whole goal of that is to do that through early detection in asymptomatic women. And the greatest potential from screening is providing early access to effective diagnostic and treatment services. Breast cancer treatment has really risen quite a bit during the last few years. And it doesn't matter if you're insured or uninsured. Everyone incurs costs when it comes to cancer treatment. Insured women incur variable out-of-pocket costs, and it all depends on their insurance provider. But as you can see from my slide, uninsured women really do sustain quite a substantial cost. And those costs can vary depending on where you are in the state, where you are in the country. Mastectomy alone can be up to over $50,000. Lumpectomy followed by radiation can be over $35,000. Chemotherapy in itself the costs have risen exponentially. And you're looking at somewhere over $100,000. And that could be per year, depending on the drug, the method of administration, and the length of treatment. And then depending on the individual case and the type and the number of treatments needed, really the total cost of breast cancer treatment on average can reach over $300,000. But it all comes down to starting with the mammogram. National organizations have issued different breast cancer screening guidelines, and that's added to the confusion from when to start, how often to screen, and when to start. But really, despite the areas of confusion, there really are some that are in agreement. The first one is the breast self-exam. It's not been recommended for quite a while among the national organizations, and rather it's been replaced by what we call breast awareness, and that is women should know their breast, be alert for any changes in their breast, and notify their provider. But clinical breast exam at this point is not recommended. Evidence has been insufficient to show that it has done anything to impact breast cancer mortality. And mammography, although not perfect, and we know it's not perfect, it's still considered the gold standard for breast cancer screening. So let's look at the guidelines. Well, in looking at this evidence that is out there, did I slip too much? I think I did here. No. Sufficient evidence has shown that breast cancer mortality is really reduced in women 50 to 74 years of age, and that mortality in these women benefits substantially. They outweigh the risk of radiation-induced cancer from mammography. And there has been sufficient evidence that's shown mammography does detect breast cancer that would have never been diagnosed. You may have heard things lately coming out how we are over-treating cancer, specifically what we call the DCIS, the ductal carcinoma in situ cancers. Because we're never sure which one of those cancers are actually going to become invasive. And there is limited evidence that also shows in breast cancer mortality in women 40 to 49 years of age. So now looking at the guidelines. As you can see from across the board here, and I pulled guidelines from the American College of Obstetrics and Gynecology, the American College of Radiology, ACS, Medical Association, NCCN, and the Task Force. And the two that probably differ the most are the ones that came out last year. And those are the ACS guidelines and the Task Force guidelines, because those are the two that start with different ages regarding screening. ACS starts at 45, but they do say it should be a woman's individual choice between 40 to 44. And the Task Force starts at age 50. As for the age to stop mammogram, it varies slightly, not a whole lot, but I think most guidelines agree that it really has to do with the woman's life expectancy, and depending on how long she is expected to live as to whether or not you should screen. And the whole point of that is, if she's diagnosed with cancer, then would you treat her based on that? Interval screening, again, the only ones that differ are the ACS now and the U.S. Task Force. Everyone else says annual. And then you'll see something that's really coming more to the forefront, and that's Tomo Synthesis, and I'll be talking more about that in a little bit. Tomo Synthesis is approved by the FDA, but it's not supported by the task force, and that's very important because it gave it a grade I for insufficient evidence. And the reason why that's important is the Affordable Care Act says that whatever the task force then recommends is what insurance companies must cover as preventive services. And as you can see, Tomo is not recommended. So even though there's some evidence out there about it's really promising, as of right now, it's not something the task force would support. Therefore, many insurances right now do not cover Tomo Synthesis. So which guidelines should providers follow? With all the guidelines out there in the Breast and Cervical Cancer Navigation Program, I think the consistent message that we give is that as a woman, age 40 and older, really you need to discuss with your healthcare provider what that individual risk is for developing breast cancer and when to begin breast cancer screening. For some women, age 40 is the age to start. For other women, it may be age 45. Average risk women, though, should undergo, and you'll see the term there, regular screening, not annual screening. And regular screening is what is determined between the woman and her health provider. And the goal is we want early detection of breast cancer because it is more treatable and it is more cost-effective to treat, and better chances of survival if caught early. And then women that are at higher risk for developing breast cancer, and the example here, if they have a strong family history, they may need additional imaging tests beyond the mammogram. So let's switch for a little bit and talk about breast density, because that is quite a big thing lately over the last few years. Lots of legislation has been passed regarding breast density, and the question comes out to play, does breast density actually play a factor in determining screening recommendations? Well, as many of you may know, last June, Michigan passed a breast density law. I was privileged to actually be asked to provide some input into the law, although I would have liked the language to be a little bit more, as we call plain language. But this language here, when you compare it to languages in other states regarding the official notification that women receive from radiologists, it actually doesn't fare too bad. But because that print's small, I'll read it. Any woman who has what's considered heterogeneously dense or extremely dense breasts, and I'll talk about that in a minute, they will get this information written to them that's in addition to their mammogram report from the radiologist. And it has to be exactly written just like this is here. And it says your mammogram shows that your breast tissue is dense. Dense breast tissue is very common and is not abnormal. However, dense breast tissue can make it harder to find cancer through a mammogram. Also, dense breast tissue may increase your risk for breast cancer. This information about the results of your mammogram is given to you to raise your awareness. Use this information to discuss with your health provider whether other supplemental tests in addition to your mammogram may be appropriate for you based on your individual list. And a report of your results were sent to your ordering physician, and if you're self-referred, then you would get a copy of this yourself. So, as I mentioned, lots of laws have been passed over the past few years, from 2013 to 2016, as you can see here by this slide. There are many advocates out there right now in promoting breast density legislation because they feel that providing supplementing imaging to women who have dense breasts will identify a cancer early. And that may be true in some cases and may not be true in other cases, and I'll show you why in a minute here. Before I talk a little bit more about breast density and imaging, I think we need to understand exactly what is breast density. A lot of people think that breast density is the actual physical palpation that a clinician does on a woman's breast, and it depends on if you feel lumps or whatever. And actually it has nothing to do at all with breast density. Really, breast density is clearly a mammographic finding. And the easiest way to explain it is the density of it is the measure of glandular tissue to fatty tissue, as you can see here in the slide. The breast on the left for fat density looks more clear compared to the one on the right, which is extremely dense. And the extremely dense breast has a lot of white in it when it shows up on a mammogram image. So it's very difficult to look and see is there something else in there that we may be missing. Breast density, is classified by the American College of Radiology using what's called the BI-RADS reporting system, and that stands for Breast Imaging Reporting and Data System. And it gives 4 actual levels from BI-RADS 1 to BI-RADS 4 in looking at the breast being almost entirely fat to the breast being extremely dense. And to better show that, I like this picture here, because you can clearly see moving from left to right that the breast way on the left, that's less than 25%, a little bit easier to see through that than the one way on the right, which was extremely dense breast. And it is really what's called the 3rd and the 4th level, the heterogeneously dense and the extremely dense breast. That is where the concern is, that when you're taking a mammographic image and seeing those breasts, it is difficult then to see, is there a problem or is there something hidden there? To give an idea of what the distribution of breast density is across the nation, about 46% of women actually have heterogeneous or extremely dense breasts. So almost 50% of women do. And the biggest impact of that is masking. So when they say that breast density is a risk factor for breast cancer, it is because it can hide a tumor or an abnormality that can't be seen until it's much larger. And as you can see here on the left, it is mostly a fatty breast there, and you can clearly see the abnormality there, and that is a cancerous tumor. Whereas on the right, I'm not really sure exactly where that is, or if there is one there at all. So it is very hard to try and visualize it. One thing a lot of women don't know is that density does change over years. And actually, a woman's breast density can change from one year to the other. And it depends a lot if she's going through menopause or if she's having any of these changes here that you see on the screen. Just as women get older, our breasts become more fatty. Women that are heavier have fattier breasts, and sometimes women that are taking certain medications. You can just see the decrease in the breast density there. For increase of breast density, if a woman's lost a lot of weight, she can get more dense breast. A lot of concern with the hormone replacement therapy that many women were on years ago. And then when women came off, what happened was they suddenly had breast cancers develop. Well, in addition to being on the exogenous hormones, the other issue was that it made the breast density to the point where it was difficult to see if there was anything being hidden there or masked, as we said that. Now, the concern about breast density is that it is very subjective, and there's a lot of variability among radiologists in categorizing density. So even though we have the BI-RADS category, really there's no true gold standard. And right now the BI-RADS are really only used in the U.S. When the task force, when they were going through and making recommendations, and they looked at breast density review among radiologists, what they found was that the same radiologist could actually change density 23% of the time. And a different radiologist can change the density in 33% of the time. And 13 to 19% actually change between dense and non-dense. So that's like one year when a woman may get a letter saying she has very dense breasts, and then the next year she may not get a letter. She's like, well, what happened? How come it changed? Well, and there's a lot of reasons why her breast density could have changed, but a lot of women don't know that. And that's why it's so important to do this clinical assessment with the woman and have a discussion with her. Some women are very concerned about dense breasts and that they're hiding possible cancer. Other women are not. Depends a lot on the patient's risk factors. Is she at high risk of developing breast cancer with a strong family history or own personal history? There has to be a discussion for a tolerance of what we call negative side effects. And the negative side effects of screening are overdiagnosis, and what I mentioned earlier. And that if you find something, you have to do something about it. In many cases, a lot of women are going for biopsies that may not need to go for biopsies. Patient education is really crucial, and I have some education resources I'll talk about in a minute here. And just to have the woman understand what it means to have a dense breast and what the implications are for her, it's really important to have an in-person discussion on this because many times it may lead to a referral based on her risk for genetic counseling. If she has particular high risk and she has particularly really high dense breast, then this is a woman you want to pay closer attention to. She's not considered your average risk woman, and this is someone that may need some supplemental screening. So here is an example I mentioned about some provider education. 2 years ago, when we were the Department of Community Health, and now we're the Department of Health and Human Services, we contracted with the University of Michigan and Dr. Renee Pinsky, who is the chair of the Michigan Cancer Consortium Breast Risk Committee. And we were looking for education for primary care doctors on how do you do that clinical assessment and that clinical counseling with women on dense breasts. So we developed a website. And if you have not seen this website, I strongly encourage you to just look at it. It is a wonderful website. And we call it the Michigan Breast Density Notification. And it has both patient and provider resources. For providers, it's a series of 6 CME modules. And you can do them at your own pace. They're all video-based. But it talks about the legislation. It talks about lots of evidence, much more than what I put here on the slide because of the short period of time here. Regarding the efficacy of imaging modalities and also the impact on breast density. And then we borrow from the American College of Radiology their patient brochure, and this is a wonderful brochure for patients. Very nice. It's just 4 pages front and back, and it goes into really what is dense breast and as a woman what you need to know about it and know about getting screened. So, and this is downloadable from that site. So if you've not seen these, I encourage you to look at those for your patients. Okay, we're going to switch gears just a little bit here. I'm going to talk about some imaging modalities because there are several out there. And I think when we're talking about breast density and we're talking about screening for high-risk women, a lot of people think that the newest modality or more is better, and that's not necessarily the case, as shown by some of these clinical trial studies. The first one I want to go back about 11 years, and actually I first became familiar with this probably about 13 years ago, and it was with the digital mammography trial. We were approached here at the time was Department of Community Health by Blue Cross and Blue Shield to come up with a position statement on whether or not digital mammography should be covered over film screen mammography. At the time, there really wasn't enough data, so we were waiting until this 2005 trial came out. And what it did was compare digital mammography with film screen, and what it actually came out and showed was digital mammography was more accurate, especially in women under age 50, because these women have dense breasts, majority of them, greater than 50% dense, and that they were also very good in pre- or perimenopausal women who have very dense breasts, in identifying if there were any other problems or abnormalities. And since then, we have greater than 98% of all mammography units in the U.S., they are now digital, or they're converted into digital. So there's very few film mammography machines left. Actually, the interesting thing that showed with the digital mammography study is that for women over 50, the women who have the predominantly fatty breasts, it was just as good as film screen. So it didn't show any difference there. But because of the efficacy in showing for women under 50, that's where it took off. So I have some pictures I want to show you of the difference between digital and film. And you can see on the left, this is a sebaceous cyst, and you can see about 2/3 of the cyst there. But if you look on the right, you can see the entire tail of the cyst. So you can see really exactly how big it is and how far it goes. So and that's with the digital mammography. The other good thing about digital mammography is the image enhancement. It gives you what's called a soft copy, so the radiologist can actually play with the digital image. And as you can see on the pictures I have here, you can make it, the image, you can manipulate it. So you can make it what I call crisper. And as you can see, there's a really nice size. Actually, it is a malignant mass that's showing on that film there. But before with film, it was you took a picture and that was it. You got what you got. But with digital, if you can kind of do a little playing around with it, so it can give you a better picture. In addition to digital, over the last few years, what has come out are what we call supplemental screenings. And these are all in addition to mammography. Remember what I said, mammography is the gold standard. So these other imaging that I'm going to talk about are all in addition to mammography. They do not replace mammography. So let's start with screening ultrasound. When I started in the breast and cervical program and we did ultrasounds, they were purely only for diagnostics. And the reason for doing an ultrasound was really to determine, is this a cyst or is it a solid mass? Because if it's a cyst, most often than not, you could leave it alone. Or if it bothered the woman, you would aspirate it. But if it was a solid mass, then definitely she'd have to go on and get a biopsy because you actually needed tissue to confirm or rule out a cancer diagnosis. In 2008, though, a study was done. This is really when a lot of, really part of the grassroots were really starting regarding breast density laws. And the American College of Radiology did a study to compare screening mammograms versus screening ultrasounds in over 2,600 women. And these women had to be at what they called increased risk for developing breast cancer. They had to have breasts that were more than 50% dense. And they determined this based on their personal history, previous if they had a high-risk biopsy, or the Gale model. And the Gale model was first brought out, in the 1990s. And that was the one that confirmed that women that had a higher risk for developing breast cancer, that they would benefit from chemoprevention. And tamoxifen was the drug that was commonly prescribed. So what this study showed was, and they followed these women for 3 years. The first year, there was like 4.2 additional cancers identified out of 1,000 women. And then in subsequent years, there was about 3.7. So it identified a few more cancers, not a whole lot more, but it did identify some more. And what it did show also, if you look at the left here, it says a dense mammogram. You really can't see the definite abnormality. And then on the right, when there was an ultrasound, the ultrasound shows the irregular borders of what's an infiltrating ductal carcinoma. If the ultrasound showed a cyst here, it would probably be more, it would be like black in the middle, because it'd be more what they call hypoechoic. But in this case here, because it's irregular and you can see, lots of, looks like debris in it, it's not infiltrating ductal cancer. So with ultrasound, then some other studies have come out, not a whole lot to date though, on what's called automated ultrasound. The jury is still out on automated ultrasound right now because there's a lot of concerns with it. There's a high recall rate on it. When you look at the cost-benefit ratio, there's many images that are done and very low reimbursement on this. And there's a learning curve for radiologists and techs to learn on how to do this. So, in looking at the evidence, if you look at ultrasound as an adjunct to mammography in women with dense breasts and negative results on mammography, there is sufficient evidence to show that it increases the proportion of false positive screening outcomes, but there's inadequate evidence to show that it reduces breast cancer mortality or the rate of interval cancers, and very limited evidence to show that it does increase the breast cancer detection rate. So moving on now to MRI. When MRI first came out, I remember in the breast and cervical program, we were inundated with requests because it was like the newest thing and it could give you much better imaging. But there's a lot of issues with MRI. Again, it may be used in addition to mammography, but it's not for average risk women. It's really for high-risk women. And the goal is to detect breast cancer in its earliest stages. But MRI does have a number of limitations. It is much more sensitive than mammography, so you get that higher recall rate. There's like 31% compared to 11% for mammography. Higher recall rate, more biopsies. You find something on an image, you can't just ignore it. You've got to do something about it. You cannot visualize calcium deposits with MRI. And typically your calcium deposits are what your early cancers, like your ductal carcinoma in situ, DCIS, that is really the cancers that are diagnosed from that. And mammography can certainly tell calcium deposits. And MRI is much more expensive than a mammogram and is clearly not reimbursed by all insurances, especially if the woman is high risk. So to give you an idea for MRI, there is a contrast injection that needs to occur for that because really what you want to do is you want to highlight the areas that are suspicious. So here on A, it sees a fibroadenoma, and on B, it's called spiculated. That's what some cancers do. They throw out like little arms, and that's how you can tell that could be a cancer. 5 minutes after the injection, it looks a little bit darker, and then they do what they call subtractive images, which means they take out all the other stuff in the breast, and all that's visible then is the cancer, and you clearly can see the cancer there. So, let's go back to the evidence for screening high-risk women. Well, as for MRI as an adjunct to mammography, there really is inadequate evidence that it reduces breast cancer mortality in women with a BRCA1 or 2 mutation. And it does increase the detection rate of breast cancer in women with lobular carcinoma in situ, or what they call atypical proliferations. There are times when a woman may have a biopsy and they'll say that it brought back atypical cells. And the atypical cells are not cancerous cells, but those cells are abnormal enough that they could then turn into a cancer down the road, and that puts the woman at higher risk. So she's monitored much more closely, but there is inadequate evidence for that. In looking at ultrasound as an adjunct to mammography, it increases the detection rate of breast cancer in women with a personal history of breast cancer, and increases the proportion of false positive screening outcomes in women with a personal history of breast cancer, as compared to those without such a history. And then when you throw all three together, MRI with mammography plus ultrasonography, you're going to get increasing the proportion of false positive screening outcomes in women with a personal history of breast cancer. And then if you compare them, mammography with MRI versus mammography alone, again, you're going to increase the proportion of false positive screening outcomes. And these are particularly in women with what they call a lobular carcinoma in situ or an atypical. So moving on now to Tomo Synthesis. And a lot of people have been calling Tomo Synthesis the new mammogram. It was used for other imaging modalities, but in the 1990s it was modified for use for breast cancer screening. And really what tomosynthesis is, it is like added on to the digital X-ray mammogram. And it does multiple projections, and it's an X-ray source that kind of moves in an arc. And so what it does is it's like taking these little snapshot pictures along the entire breast. There are benefits to tomosynthesis. It does increase the cancer detection, all densities, and there's many studies on this. And it does decrease the recall rate. It removes what's called superimposition. There are times that women may be called back for additional studies for a mammogram because the way the breast sort of superimposes on itself, the radiologist really can't tell, is that breast tissue there, normal breast tissue that's kind of pressing stuff together, or is there really an abnormality there that he needs to look further in, or she needs to look further into. And to give the idea between the two, digital mammography is what we call the screening 2D. Sometimes you may hear tomosynthesis referred to as, the new 3D mammogram. That's tomosynthesis, because that's really what it is. It looks at the pictures in 3D, and it takes these spatial pictures that you can see where the circles are covered, and it more than digital, more fine-tuning to really bring that there's truly an abnormality there that we couldn't see on just 2D mammogram. And it does what's called image slicing. So it goes from literally takes slices of the breast as it does its views through it until you can clearly see that there really is something there to focus on. There are advantages to tomosynthesis. The big one decreases false positives, and I've been talking all along here about all the false positives and the recall that's coming back with some of the other imaging modalities. So this really does help radiologists because it helps distinguish harmless abnormalities from real tumors, and that was up to a 40% based on one study. So it is quite high. Much less anxiety for women. If you've ever been called back for a mammogram or been called to get a biopsy, that is so anxiety-producing for women because immediately what they think is, oh my God, I have cancer. Even though about 90 to 95% of biopsies are benign, it's still very prevalent and very fearful for many women to think that. Also, it increases the cancer detection rate because you get better depiction of masses in dense breasts, including the associated findings surrounding the mass. So if there's a dilated duct or there's a vessel, and it shows microcalcifications. But it does have limitations. There is a 2 times greater radiation dose than with mammography, and it does take longer. So as a woman who gets mammograms, you need to spend a little bit longer time in compression. And if you've had a mammogram, that's not very comfortable because there needs to be some time to synthesize that 2D image from the 3D image. So there's still some increased interpretation time. And it's what they call a still mammographic technique. So you need some type of a contrast between the tissues, especially if the breasts are very dense. So it's not the best thing since sliced bread, I guess I could say. And as of right now, it's not replacing mammography. Mammography is still the gold standard. So let's look at mammography with tomosynthesis. Well, a lot of women, when they go getting their mammograms now, they may automatically have tomosynthesis done with it because there is sufficient evidence, and it's been shown to increase the detection rate of in situ and invasive cancers. But there has been limited evidence that's shown to increase the detection of invasive cancers. And there's also, it reduces the proportion of false positive screening outcomes. And then there is really no evidence to show that it reduces breast cancer mortality or the rate of what we call interval cancers. Interval cancers are those that pop up in between mammogram screenings. And for higher risk women, those are the ones that they would be monitored more closely for. So what do all the studies cost? Well, as you can see at the bottom there, Tomo is pretty cheap from a Medicare point of view. These are all Medicare rates. Even compared to a digital mammogram, it's $131. Of course, the MRI is more expensive. So it's fairly cheap. Regarding coverage for low-cost women, the Breast and Cervical Cancer Navigation Program does provide women that we call less than 250% of poverty, ages 40 to 64, And that 250% is about $39,800 for a family of two. So we'll take women into the program who are uninsured, but mostly what we see into the program are now underinsured women. So even though the Affordable Care Act has done wonderful things in mandating that all preventive services have to be covered, that just means the mammogram has to be covered. Depending on the woman's insurance, it does not always mean the diagnostics are covered. So in our program, we will pay for your diagnostics for your ultrasound. We'll pay for MRI on a case-by-case basis. Unfortunately, we cannot pay for Tomo Synthesis. Even though it is FDA approved, because the task force is still saying insufficient evidence on it, and we're funded by CDC through the Breast and Cervical Program, that's an imaging modality we're unable to pay for. Women can call, and I apologize there, that number should be 844, not 800. So it's 844-I-SCREEN, and they can just put in the first three letters, SDR. This is our new number. We're going to be putting this out this summer, and women can call, and we will hook them up to their nearest agency, and they can then register to be enrolled in the program and receive either screens or diagnostics. So in summary, I know I threw a lot of information out here. If you're looking at an average risk woman with any breast density, what do you recommend for her? Well, as I said, screening mammography is always the gold standard, and add Tomo if it's available. So you're having your 2D plus your 3D mammography. But no supplemental screening is supported by any of the national organizations, which sort of goes against a lot of the breast density legislation, because a lot of it says a woman may qualify for additional imaging modalities based on her density of her breast, but then the conundrum is her insurance may not cover it. Intermediate women are those that we consider 15 to 20% a lifetime risk based on the models that are out there. That means the woman could have a personal history of breast cancer, or she could have what we call LCIS, lobular carcinoma in situ, or the atypia that I was talking about before on the biopsy. But the management for this is more muddy. There's experts say do an annual mammogram with Tomo Synthesis if it's available, but regarding for supplemental breast imaging, MRI may be usually appropriate, ultrasound may be appropriate, but depending on that subjective categorization by the radiologist, if the woman has dense breast, she may be bumped to another category, in which case then supplemental screening would then be more considered. But she's kind of in between right there. And then high-risk recommendations are women that have greater than a 20% lifetime risk. And their 5-year risk is greater than 1.7. And that 1.7% comes from the Gale model. And that was the model that was done in the 1990s regarding what was a woman's risk for getting breast cancer and whether or not she was a candidate for chemo prevention to reduce her risk. These women are also what we call BRCA positive, or they've had a history of thoracic radiation, or some rare genetic syndromes that could increase their risk. So the recommendation here, annual mammogram, again with Tomo Synthesis if available. But with these women, you really want to look at an annual screening MRI, regardless of their breast density, and a screening ultrasound only if the MRI cannot be performed. As for dense breast, the gold standard's right there again. Screening mammography if they're greater or equal to age 40. Discuss with the women, acknowledging limitations, that breast density is very subjective, and it can change from year to year. It can vary with the patient. It can vary with the technical factors. Depending a lot on what are all the risk factors that will increase the woman's risk for getting breast cancer. And provide a lot of reassurance. Breast density is a very small risk factor. A lot of women get very hung up on that. But really, there are a lot of other risk factors that will increase her risk for getting breast cancer. Supplemental screening options, what are the strengths and the weaknesses that she may be called back in for additional imaging or biopsy, and then she may need genetic counseling if she falls into that category. So, again, just in summary, high-risk patient, annual mammography, MRI, low risk, annual mammogram, Tomo if available, address controllable risk factors. Intermediate risk, that's the muddy area. Definitely an annual mammogram, but you may want to consider a screening ultrasound or MRI, but the false positives and the cost definitely have got to be considered. And that concludes my presentation, unless there are some questions.
Ladies and gentlemen, if you have any questions at this time, please press star 1 on your telephone keypad. Again, if you have any questions at this time, please press star 1 on your telephone keypad. And Julie, I'm waiting for callers to join the queue at this present time.
All right, thank you. While we're waiting for people to get into the queue, I did have a question for you, EJ. I think you touched on this briefly before too, but have you seen this increased awareness of dense breast tissue relate at all to how frequently people are being referred now for genetic testing for the BRCA genes? Have you seen like an increase in frequency at all?
Not related directly to the breast density. I haven't, no. And actually, in our program, what we do is we look more at other risk factors, not really the density, depending a lot on the woman's age and what her history is, and the honest also if she's African American, because they have a higher risk. More than that, probably about 12 years ago, it was that white women had a higher incidence of breast cancer and black women had a higher mortality, and that's not the case anymore. Now, black women both have a higher incidence and a higher mortality, so that puts them at a higher risk.
Okay, thank you. At this time, let's pull up the evaluation questions. Please take a moment to let us know how we did by filling these out. And operator, if we have any further questions.
There are no questions in queue, but again, if you have any questions, please press star 1 on your telephone keypad. No, Julie, no one joined the queue.
Okay, well, thank you for joining us today for Breast Cancer Screenings, Risk and Preventative Measures. The recording of this learning session will be posted on our YouTube channel within the next week. The link to our YouTube channel is in the chat box. And thank you again so much, EJ, for joining us today.
You're welcome. Thank you.
All right, thank you, and have a good day.
You too. Bye-bye.
I would like to say, ladies and gentlemen, thank you for joining. This completes your conference call. You may all disconnect and have a great day.